Hello, I'm Dr. Aaron Burnett, Assistant Medical Director at Region CMS.
And I'm Dr. Ryan Borden, an emergency medicine physician and the current Quality and Patient Safety Fellow at Regions Hospital.
Today, we're going to review some of the latest updates in stroke care and introduce you to a new process for giving a patient care report to both MRCC and the stroke team when you activate a pre-hospital stroke code at Regions Hospital.
Stroke care is a rapidly evolving area of emergency medicine. At Regions Hospital, we are fortunate to have emergency medicine physicians and neurologists who are on the cutting edge of stroke care. We participate in 3 large multi-center research trials, which are expanding the treatment options available for patients with both ischemic and hemorrhagic stroke. Our capabilities include non-invasive treatments to dissolve clots with a powerful medication called Tpa, as well as invasive neurointerventional and neurosurgical therapies. At Regions, our approach to treating stroke patients is modeled on the multidisciplinary team concept, which have proved very successful in the care of our trauma patients. The first component of this team is EMS, who initially assesses, stabilizes, extricates, and transports stroke patients.
Let's focus in on the key aspects of pre-hospital stroke care. Dispatch and the first responder have an important role to play in the stroke chain of survival. Interrogating callers to identify symptoms of stroke allows emergency medical dispatchers to send appropriate resources and to provide pre-arrival instructions.
Strokes are a time-sensitive condition where the longer it takes to restore normal blood flow to the brain, the lower the chances of a good outcome for the patient. For every 1 minute that blood flow is interrupted, 2 million brain cells die. The quicker we can get stroke patients to the hospital for treatments to dissolve or remove a clot, or in the case of hemorrhage, to control the bleeding and limit increases in intracranial pressure, the better the prognosis for the patient.
For EMS, stroke patients should be thought of in the same way as STEMI and trauma patients. Limiting out-of-hospital time is a key metric of high-quality stroke care. It's also a component of high-quality care in STEMI and trauma patients. Minutes count, and limiting on-scene time and responding using a Code 3 response to both the scene and the hospital are appropriate in cases of acute stroke. Currently, acute strokes are defined for EMS as the patient having a last known normal time of less than 8 hours. For patients who have symptoms of less than 4.5 hours in onset, intravenous clot-busting medication such as Tpa is the first-line treatment. For patients who were last known normal in a window of time from 4.5 to 8 hours prior to EMS contact, neurointerventional approaches are generally the initial treatment option. However, stroke care is rapidly evolving, and these timeframes may change. Ultimately, even if these timeframes change, recognizing an acute stroke and minimizing out-of-hospital time will ensure the patient has the best chances of a full recovery. Today, we are going to introduce a new method for EMS to communicate critical patient information to the receiving stroke team at Regions Hospital. This stroke code timeout is modeled on the trauma team timeout process, which has been very successful at Regions. The mnemonic we will use to help remember the critical information to be communicated is CLOT. This stands for the Cincinnati Stroke Scale Abnormality, the last known normal time for the patients, other family members coming to the emergency department, and treatments by EMS, including finger-stick glucose.
Let's review the Cincinnati Stroke Scale, which is an easy-to-use, accurate method for assessing whether patients are showing signs of stroke in the pre-hospital environment. There are 3 parts to the Cincinnati Stroke Scale, and each of them tests a different part of the brain. If the part of the brain being tested is not receiving adequate blood flow, then abnormalities will be seen. The first part of the Cincinnati Stroke Scale tests speech. In around 75% of patients, words are formulated in the left side of the brain. If this area is ischemic or injured, patients will have trouble understanding words, or they may be unable to formulate words. Speaking requires a functioning tongue to pronounce syllables. The best way to test speech is to ask the patient to say, "You can't teach an old dog new tricks." Slurred speech, or inability to comprehend speech, would indicate that a patient fails this aspect of the Cincinnati Stroke Scale. Next, test the motor function in both arms. To do this, you should have the patient extend both hands out in front of them. Some providers only test a patient's grip strength, but the problem with this is that it does not test the larger, more proximal muscles of the arm, such as the deltoid. This test is abnormal if one of the arms falls relative to the other arm. Finally, test for facial asymmetry by asking the patient to smile or show you their teeth. If there is a facial droop present, this suggests an abnormality in the part of the brain that supplies the 7th cranial nerve. If any one of these 3 tests of the Cincinnati Stroke Scale is abnormal, there is a 72% chance that the patient is having a stroke.
The L in CLOT stands for last known well time. Once a stroke has been identified in the field, EMS providers need to begin making plans to extricate the patient to the ambulance and clearing the scene for the hospital. The treatment options that are available to the patient are dependent on the time since the patient was last seen normal. This is a critical data point that EMS is able to identify, and it will directly impact the care of the patient. The start of the stroke clock begins when the patient was last seen normal. If the patient wakes up with symptoms, then the time they were seen prior to going to bed was their last known normal. For patients who can get to the hospital and have their head CT performed in less than 4.5 hours, intravenous TPA is the preferred treatment. This can be given at many community hospitals, including Lakeview Hospital in Stillwater and Hudson Hospital in Wisconsin. For patients in the 4.5 to 8 hours from last known normal window, the preferred treatment is a neurointerventional approach. Neurointerventional approaches are only available at the tertiary care centers, which include Regents, United, and St. Joe's in the East Metro, as well as the University of Minnesota and the VA.
The O in the CLOT mnemonic stands for other family members responding to the ED or others. Many patients suffering a stroke are elderly, and sometimes dementia makes it difficult to assess treatment options, risks, and benefits directly with the patient. Family members often know the patient's wishes and can help in shared decision-making regarding how best to proceed with treating a stroke patient. EMS is in a unique position on the scene to encourage family members to come to the ED. We would encourage EMS to bring the family member closely related to the patient, such as a husband, wife, or adult child, and preferably the patient's power of attorney if known. Having this family member immediately available in the ED will help us decrease the time from door to TPA if that is the treatment course that the patient chooses.
Finally, EMS should communicate the treatments that they give en route. Start with the results of your finger stick glucose. Hypoglycemia is a common stroke mimicker, and ensuring that this has been eliminated from the differential diagnosis by EMS facilitates our rapid transport to the CT scanner. Other pertinent data points may include the interpretation of the patient's cardiac rhythm, as atrial fibrillation is a risk factor for stroke, and many patients with chronic atrial fibrillation are on anticoagulants like Coumadin, warfarin, or Pradaxa.
Now that we've reviewed each of the components of the CLOT mnemonic, let's walk through a typical EMS to hospital communication for an acute stroke patient. Ideally, EMS should activate a pre-hospital stroke code via MRCC once they have identified a patient with a time of last known normal of less than 8 hours and an abnormality on their Cincinnati Stroke Scale. When MRCC receives a pre-hospital stroke code, they will inform the charge nurse who will activate the ED stroke team. On arrival, a member of the ED staff will meet EMS at the door and will lead the EMS crew and patient to an area just outside the ED scanner where a provider and nurse will be waiting. An ER clerk or coordinator will quickly register the patient so a head CT and other orders can be entered if necessary. The stroke team will then receive the EMS handoff, which includes the CLOT mnemonic, abnormality identified on the Cincinnati Stroke Scale, last time known normal, other family members coming to the ED, and treatments by EMS, as well as any other relevant information that would otherwise be included in an EMS handoff. The provider will briefly evaluate the patient and decide whether to proceed directly to CT or to a patient room. Patients going directly to CT will be transferred from the EMS stretcher directly to the CT table or to a weighted bed. Bypassing the initial rooming of the patient will create additional opportunities to decrease door to CT time and door to TPA or intervention time, and therefore optimize care of these critical patients.
This is an exciting time to be involved in the care of stroke patients, as the therapeutic options available are improving. As medical professionals, EMS providers are a key component in the chain of survival for this patient population. Remember the CLOT mnemonic when dealing with acute stroke patients, and we'll see you in the ED.